for Tyler Glory Jordan to give the invocation, please.
Our Heavenly Father, please assist us today in making decisions, the proper decisions for the Cherokee people. In our meeting today, please guide us with your hand in assisting Cherokee Nation as a whole as we go into our health meeting today. And please allow each of the folks here today a safe route and route home and to continue their work for Cherokee Nation.
Next is roll call.
Bradley Cobb.
Donnie.
Janelle Fulbright. Here. Jewel England.
Here.
Bill John Baker. Jack Baker.
Here.
Harley Buzzard.
Here.
Julia Coates. Here. Joe Crittenden.
Here.
Jody Fishinghawk. Here. Meredith Fraley. Here. Don Garvin. Tyler Glory Jordan. Present. Curtis Snell. Krista.
Here.
David Thornton. Sarah Callan Watt. Oh, honey, we have a forum.
Next, we have approval of the July 15th minutes.
So moved.
Second. We have a first and a second. All those in favor, say aye.
Aye.
Any opposed? Motion carries. Next on the agenda is, yes, Councilor Jordan.
I would like to make a motion to amend the agenda to add an item 3 to new business, and I would like to pass around an act that I have asked Todd Hembry to prepare regarding the assumption of the Hastings Hospital. I think you have a copy, and you have copies. Let's see, who doesn't have a copy over here? Okay. You'll take this around. Okay. This act would provide for a future direction for our Department of Health. It mentions in it the assumption of the Hastings facilities as well as clinics that have been previously mentioned in a number of health meetings, as well as a assurance to the workers at the Hastings Indian Medical Center that the IPAs will continue that have been worked out by our health department. And I would ask that that be placed under new business as item 3.
We have a motion to amend the agenda for item 3, and we have a second. All those in favor, say aye.
Aye.
Any opposed? No. 1. Motion carries. So we have item 3 under new business will be act establishing Cherokee Nation assumption of all functions, what Ms. Gordon just read. Next, we have the Claremore Service Unit. I believe Marty is out. We have Ms. Teehee. Is that correct?
My name is Melinda Teehee, and I am the Chief Nurse Executive at the Claremore Indian Hospital. And I understand that Captain Smith had already sent a copy of his report. I don't have anything to add to that, so if there are any questions.
Councilor Soap.
Yes, I had talked to, I guess I'd sent some communications to Marty, and it was requesting some follow-up to some situations to where people had been referred to several different medical centers through the IHS facility there in Claremore, and then they were receiving bills from these different facilities, and so I haven't heard any feedback from Marty, and it's been some time, and I was just wondering if you could see if you could follow up on that.
Yes, sir.
Provide that information.
I'll talk to him. He'll be back at work tomorrow.
All right, I appreciate it. Thank you.
Councilor Jordan.
I need to find out a little bit more about Claremore. How many employees do they have?
About 350.
350. And what is our budget? Just an estimate would be fine.
15 million. I don't
15 million.
Yeah.
And of the employees, can you just kind of give us a breakdown how many are permanent and how many are temporary? And I'm not real knowledgeable about your status there at a federal facility, but I understand some are permanent, considered permanent
Yes, there are
employees.
some permanent and some temporaries. Most of the temporary staff are in medical records and registration and more on the business side of the house.
Kara, do you know, since you're on the board there?
No, I don't know how many temporary staff, because I guess that's some kind of IHS designation, and I didn't realize, because I don't differentiate if they work at Indian Hospital or staff to me, so.
Okay, so it's quite a bit smaller, I guess, than Hastings,
Yes.
isn't it?
Yes, ma'am.
And how many patients can you take in the hospital facility at a time?
In the inpatient side of the house, we have 50 beds.
50?
50, yes.
Okay. And that's compared to Hastings, how many beds would they have?
61, is that right? 60?
So the difference probably is the clinic side.
Yes.
Okay.
40, is that per policy? Okay. I'm sorry. The budget's about 40 million, and that includes third party.
About 40. I mean, just an estimate now, and maybe Melissa might be able to add to this. What's the breakdown on third-party collections versus what the federal government provides?
It's about, I think it's about 30 million appropriated, and then about 10 million collections.
Yeah.
Okay. Is their collections as good as Hastings?
To date, we, for this fiscal year through July 31st, we have collected about $1 million.
In third-party collections?
Yes, that's Medicare, Medicaid, and private insurance.
What is your, normally for a whole year, I guess we're 10, that probably is through June?
I'm sorry.
It's through July.
Through July? So, that's 10 months?
Yes.
What's your general collection rate? Is that about right?
We are down $181,000 from where we were this time last year.
So where Hastings Hastings actually is collecting more than they're getting from the government to operate. Is that,
Just to put it in perspective, Hastings appropriated dollars is about 27 million, and their collections are about 30 million. 33 million. So they actually collect more than they get appropriated. And Claremore's appropriation is about 30 million with collections about 10 million.
collections are about 10? Do you collect 9 million in 2 months, right here at the end of the year, or how does that work? Because, did you say $1 million?
But that's what the report says.
That's probably for the month though, isn't it?
Yeah, it's for the month.
Oh, okay, that put them on track.
Oh, I am so sorry. To date, we have collected 9.6.
Okay.
I was reading from the
okay.
wrong place.
I was getting worried there for a minute.
Yeah, I was too. And that was July. We collected $1 million in July.
Okay, so you're on track then to collect your 10.
Well, we're still down, just that 181,000 from this time where we were last
I
year.
think it's more about 11 or 12. It's like
And Melissa, what do you attribute to the difference? How is ours so good at collecting, and what happens at Claremore? Can you tell?
Our outpatient visits are down this year, 15% from where we were this time last year. Our adults inpatient admissions are down 22%. Our newborns admissions are down 17%.
Okay.
And to date, in July of '08, we only made 280 new charts.
Do you think those people are coming to possibly Hastings, or where are they going? I mean, what would happen to that many people? Kara, having been on the health board, I'm sure she's real knowledgeable.
You're next, but you have the floor, and you're more than welcome to.
So this was an extensive discussion at the last board meeting, and she's filling in for the day, and she's heads our nursing department, which we don't have a shortage of nurses, so she does her job very well, so we appreciate that, Ms. T.E. But there is a combination of things going on. We have to compete against the Tulsa market for the Sooner Care, which is your Medicaid, and then, of course, Medicare opportunities. And so we've identified that there's a lot of opportunities at the Claremore facility. Of course, there's no tribal funds because it's an Indian Health Service facility. So we are an interim CEO, and Captain Smith is doing everything he can as an interim CEO, but that's always limited. And I think we just now took the opportunity to bring epidurals back to deliver babies, and the rooms have been updated. So if you'll notice on the monthly chart, you typically see newborn down, that rate's down. Well, that's a lot of opportunity for third-party revenue. Until the OBGYN ward has just now gotten updated and could actually compete maybe as a kind of a suite and look pink and all that nice stuff. And so we're trying to become more competitive with the free and public market at that facility in order to bring those dollars back to the facility. But if you will look, not only do we have a decreased patient load and decreased through charts and patient visits and the newborns, but we do not do a good job of third-party collections. We just now have somebody that we inherited from Hastings. Thank you. That's able to look at, because we have a severe, other than nursing, everything else, we seem to have a severe staffing shortage, and there's
Providers.
we are short. That's another issue, is we have a lot of providers that are missing, and so if the providers aren't there, we can't bill, we can't see the patients, and that's another reason why we're probably down on patient load, because if they're backed up and they can't see patients, then we're going to have issues. So we're missing revenue at every opportunity. The problem is, we went through a process of trying to hire a new CEO, and there was conflict between what the board wanted and what Indian Health Service wanted. So we're back at round 2, and we should have somebody in place by October, November, and I think that that'll be a good candidate.
So we're down on doctors too, it
Yes.
sounds like.
Everything.
Yes.
We've got some shortages there.
Yes.
We can't even fill our beds and stuff because there's not enough providers to delivery.
We have recently hired a new physician in the medical clinic and the family practice clinic. Dr. Molly has also hired some nurse midwives, and we've hired a chief of the OB/GYN service. He will be starting on Monday. And he's currently discussing possibilities with a couple of surgeons.
Y'all deliver a lot of babies there at Claremore.
Last year, I think it was like 358.
And how does that compare to?
Thousands.
We deliver about 1,000 here. Okay. Thank you.
Councilor Calvin Watts.
That's right.
Councilor Calvin Watts, you
Yes, sorry. I just got delivered some information, so you may not be able to answer.
I'll try.
Okay. But if you could send back, get us a response. I guess the Rogers County Sheriff's Department's decided to only transport EDOs who live in the Rogers County.
Yeah, and the last line of that memo says the Indian Hospital has to make other arrangements. And the problem came because Grand Lake closed their stabilization unit out north of town, and they didn't notify us till like 3 or 4 days after they closed it. And so now all of our EDO patients have to be transported to Wagner, and the ambulance service is taking them.
And so we have made alternative
Yes.
arrangements.
Yes.
How's that going to impact budget?
Well, we'll have to pay for the ambulance transport.
Thank you. Thank you, Mr. Chair.
Any more questions? Thank you, Mr. Next, Hastings, Ed McLemore.
Good morning, Mr. Chairman, members of the committee. We did send in a report a little late. I don't have anything really to add to the report. If you have any questions, I'd be happy to answer questions.
Are there, Councilor Fishing Hawk?
I got a couple of them. Who does people need to call about the pharmacy refill program? Can you give me a number? Or
Yeah, we can provide that number. and it's the pharmacy. I don't have the...
Just they can call the pharmacy
Yeah.
straight through and say,
Right. Or call the main number, 458-3100, and get connected to the pharmacy.
Okay.
We have about 2,200 plus folks signed up right now for that service, and we're processing mail requests routinely, so we'd be happy to take those.
It's never below what you all thought.
Well, actually, we're getting to the point where we thought we would be based upon the phone-in orders that had been physically picked up by the patients who came into those walk-in bays. We had expected to do about 525 to 750 prescriptions per day, and there's roughly 2.8 or 3 prescriptions per patient. So we thought we'd be doing about 250 requests per day, and we're getting close to that number.
Okay, the other thing about third-party collections.
Well, third-party collections, we're able to do that, and that's one of the reasons we went to a 30-day refill as opposed to the previous 90-day refill rate, because the insurance payers require that we don't fill prescriptions any more than 34 days, and 30 days, of course, is within that time frame, and that allows us then to collect reimbursements for those payers who have medication reimbursements. And this year we're going to collect around $3.1 million on the medications alone, out of about $33 or so million. So it's roughly a 10% collection rate for medications versus the total.
Will that be up from last year?
It'll be up about $200,000 from last year. We were at about 2.8 plus, just under 2.9 million last year.
Okay. And then how about third-party collections in general?
We are looking at about $33 million. We're slightly above where we were last year. I think we're about 300,000 or so above the same point year-to-date that we were last year. So we're slightly ahead of pace, but there have been a number of issues that have come up. We had hoped to see about a 6% increase based upon activity, but we're now hoping just to break even with last year.
Why is there such a big gap the last month or two that you all make up so quickly?
Well, that's just year-to-date. And so you have to put in the 2 months, and if you look at about a $2.7 million per month rate, that would be about $5.4 million for the last 2 months. So that just shows year-to-date, but that will, I mean, if we showed the projection, we would show that we would be on pace with that previous year's total amount.
Thank you.
Councilor Jordan?
Are we doing the adult walk-ins through the pharmacy mail-out yet?
There can be any patient who wants to be included on that refill by mail, simply fills out a little half-sheet bit of information, and we routinely process those, whether they come through adult walk-in or adult medicine or any other clinic up there.
So if we go to the doctor through the adult walk-in and you go, well, for example, I go every 90 days. And they give you a script for 90 days to be filled every 30 days.
Yes.
Do you fill out a new form, or is it just one form for the whole time?
Well, what happens is, once you fill out the form, that's basically your demographic information, your address and that sort of things, to make sure that we get the package sent to the right address. But each individual medication order is placed by the physician based upon your visit. So if you call in and indicate what your medication request is, it'll be based upon what the physician at pharmacy entered into your record in the system.
Okay, so we fill out the sheet, we ask for the mail out of our medicine, and our 30 days clicks along, comes up to the end of the 30 days where we've got our medicine. Do we call in to get the mail out to
Yes,
start?
yeah.
Okay, so you still do the call in?
Yeah, that's just
Okay.
to make sure we're still dealing with a actual patient. I mean, in the interim, the patient
Hasn't died?
hasn't died.
Okay, I mean, I see where you're headed with
Right,
this.
right.
You don't want to send medicine if they're dead?
Yeah, I mean, we
Okay.
just don't want to put it on automatic pilot to send out medications when we actually don't have a patient receiving them.
Okay. It seems like it will work. You've not had any complaints, right?
Absolutely not.
We're covering or you're covering the cost of the mail out?
Yes, it's about $2.74 per package. That's the average postage, and we've absorbed that within our system. And, I mean, just the savings to patients, you know, you talk about a $3.50 per
Gas
gallon,
versus-
$4. If somebody drives from anywhere around, you're talking considerable savings, at least twice during that 90-day refill period, where the patient actually does not have to come into the facility to receive their medications.
And that $2.74 average, I bet that you send all the meds in one little box?
Yes, we do.
Okay, not
Yeah.
separate boxes,
Yes.
but all one box?
Yeah,
Okay.
all of those medications that are not susceptible to deterioration based upon exposure to heat, cold, those kinds of things. I mean, they're sent through the regular mail postal system, and for those medications that are susceptible to that kind of thing, we still ask that patients come in to receive those.
Okay. And what do you contribute, your third-party collections, to being so successful versus Claremore Hospital?
Well, I think it's a very long-term process, and it's just a choice as to whether or not you're going to invest in additional services. And way back when, and I attribute the success of Hastings today to some of the decisions that were made well before I arrived on scene here. Hickory Starr, Keith Barrick, Kathy Holcroft, and others made conscious decisions to invest those revenues into additional resources, into additional services. And because it was soft money, we opted for the protection of the government, and so that we were not deficient in our spending, to hire temporaries. And that's what's gotten us into the fix today with the transition. Because of the conscious decisions to invest those resources into temporary positions, we built up a program of 600 or so employees. 60% of those are funded from alternate resources. So if you invest in more resources and services, you collect more, you are able then to reinvest in additional staff, you collect more. So over the past years, we saw the biggest jump from fiscal year 2003 to 2004, when we went from $22.8 million to $30.1 million, about a 41% increase that 1 year. So investments in services is one factor. Another is, I think, the fact that we instituted a charge master system that allowed us to identify all of those charges that we should be billing for. That's another key. And then we invested in the billing process. We instituted a coordinator for the entire revenue stream. I have a chart. It's a 11 by 17 chart. It's filled up with little boxes showing our revenue stream. And
Where all your money comes from?
all of those things that go into collecting money. The person who coordinates that entire revenue system is a business process coordinator. She's one of a kind in the entire Indian Health Service. And I think that's another key factor that has allowed us to go from, you know, the $13 million range to now the $33 million range, which translates into more medication, more services, more staff, more of just about everything except space. And we need more space.
How much more space do you estimate?
We did a study about 3 years ago, and based upon the formulas that are applied against the number of patients that come to us for care, we estimate that we need about 190,000 square feet of additional space, 190,000 to 200,000 additional square feet.
Now, you mentioned that we used a lot of temporaries, it's about 60% to 40%, and now we've moved all those temps to permanent placement. How much is that going to increase the cost of operating Hastings with all of those permanent employees?
I don't think it will increase the cost. I think it just changes the character of the resources that are directed to cover those costs. I don't think there's additional costs, it's just changing the type of appointment that the individual has.
Well, I guess what I'm asking is, will there be more money on the side that goes back to Indian Health Service where we pay for the IPAs, for example?
Well, I think it does. I think in terms of actual numbers, because we increase the
Maybe you can help
permanent.
us a little bit with that.
The interesting thing about temps with Indian Health Service is it's not the same as temps with Cherokee Nation. Our temps at Cherokee Nation, they receive a salary, but they don't get any benefits, okay? With Indian Health Service, a temp is the same as a permanent. The only they get benefits and everything. The only difference in a temp and a permanent with Indian Health Service is that a temp is on a 13-month assignment. 30 days, 60 days, or 13 months, I believe it is. And they just renew them and renew them and renew them. So they have temps that's been there 17 years.
I know, I've run across some that have been
You
there
know,
17.
but as far as pay and benefits, it's the same. So it really, the only thing it'll affect for us, well, actually, it won't. I don't think it affects anything because they come over and they're getting a benefit package, which they already had. So there's not any additional cost going to those temp employees.
Now, those that
It's just that Indian Health Service will not allow, because of federal regulation, you to have a permanent employee paid with third-party revenue.
Okay, I see.
That's the issue.
Okay. But by moving all these folks to permanent, so they can IPA, that allowed them to stay in the federal system.
Yes.
And that IPA business, that comes up every couple of years. I mean, how does...
Well, an IPA is an intergovernmental personnel agreement. It's a tool that Indian Health Service uses with outside agencies to assign an employee to that agency. That's what it does. And so the tribe does an interpersonnel agreement, and is that the one that's 3? Okay, it's a 3-way agreement. So the employee signs it, IHS signs it, and the tribe signs it. IHS, and the term of the agreement is 2 years, and that's because of IHS regulation. If the tribe or the IHS gets discontinues or once out of an agreement, the termination clause is that the tribe or the IHS has to give 60-day notice. The employee can get out of the agreement with no notice. They can get out today. They can say, today's my last day and I want out of the agreement. They remain an IHS employee, they're just not on agreement with the tribe anymore.
What about the government? How long do they, can they terminate?
60 days. If it's the government or the tribe, it's a 60-day notice.
Okay.
If it's the employee, it's no notice.
Okay.
And they can audit, the original term is 2 years, and that's because of the classification of the IPA. It's called a special IPA.
Now, we have several of those at the tribe.
We have one IPA. We have had numerous When we assumed Stillwell Clinic years ago, there was several IPAs there, and we still have one on IPA at Stillwell Clinic that's been on an IPA ever since we assumed 20 years ago. And then we had, when we assumed J Clinic from IHS, we had numerous on IPAs there that actually has retired off of an IPA.
Do we have any?
Harley's wife is one of those, so.
We have any left there,
We have,
Joe?
no. They've all retired and came, now we have them that's retired and come back to work for the tribe, which is what a lot of times they do. And we have 7 MOAs, which is the same thing, only that's for civil service for a commissioned officer employee.
How does that one work?
It's the same
I
thing.
noticed that was on your list. That
It's
there
the
was-
same, it's just called a memorandum of agreement, and because you're agreeing with a different agency besides IHS, it's now National Corps. I'm not sure what the proper name is. Lori, do you know? What's the commissioned officer, the agency? Is it National Corps? National Public Health Service. So it's the same thing, it's just the agreement with that agency, and those are for commissioned
Would
officers.
those be mostly our doctors?
Yeah.
Many of them?
It's health professionals.
Yeah.
I mean, physicians, nurses, engineers,
Yeah.
dentists, pharmacists.
How long do we make those for?
What's their term? Is it?
It,
They don't have a term, do they?
it's just. till
It's just
somebody-
a term till reassignment.
Okay, so they can be on those for,
Well, you can be on either one for as long.
okay.
It just doesn't have a term in it.
Now, we don't generally terminate the IPAs, the tribe doesn't.
We've never terminated an
Okay.
IPA in the past.
And IHS says they have never terminated an IPA. It's always been the employee that's been the one that terminates.
So really, if we wanted to give an assurance to our people that are IPA and that we would never oppose those IPAs continuing, since we've never terminated one in the past, that probably wouldn't be a problem.
Well, the generalization of that, to me, and this is just me speaking from myself, but the generalization of that is I don't have a problem with that. The problem is that I would want some caveat. I mean, you don't want somebody there that doesn't ever show up for work.
Well,
But if there are,
we
but I
tied
would say if it was not for work or performance issues, then I wouldn't have a
If
problem
we
with it.
tied it to their performance evaluation,
Absolutely.
we could probably give such an assurance then.
Right.
If we tied it to their performance
Well,
evaluation.
and we've given that assurance over and over and over to them.
All right. Thank you.
Councilor Buzzard.
Yeah, I have a couple of questions. One is in your report here, I'm just curious, Pete Beavers, Adam Jones, Earl Proctor from the Creek Nation Tribal Council bids. Can you tell us a little bit about that, Ed?
I've been thinking for some time about inviting the representatives of the Muskogee Nation who represent Muskogee and McIntosh counties to come over and receive an orientation to Hastings. And we invited the representatives from those two counties from the Creek Nation Tribal Council some time ago, and we finally worked out August the 8th as the date for them to come over, just for us to show them around the facility in the event they had members of the Creek Nation who came to them with concerns about services at Hastings. We wanted them to be familiar with us as management and to receive an orientation to the system up there. So we worked out a date and they came over. We had expected 5 council members, 3 from McIntosh County and 2 from Muskogee, but 2 of them were unable to be there. Salina Dornan and let's see, I think it was Eddie LeGrone were unable to come. We had Daryl Proctor, Adam Jones, and Pete Beaver come up. And from all indications, they enjoyed the visit and they appreciated the information that we provided.
I see. One other question. Sure.
Yes.
Hope you can tell me how this works at Hastings Hospital. If you have a patient there that's been a patient there for 20 years, and that's all they've ever used is the Hastings Hospital, 20 years later, this patient becomes disabled. Does your doctor write a disability diagnosis for that patient?
They routinely do so, yeah.
So they will, so they can go back and get the disability on Social Security or whatever they need to do.
Well, they will attest to the necessary facts in documentation, but I mean, the actual disability determination, I think, is made by a Social Security Administration or someone
But
else.
they will write up the facts.
They will support with the medical information necessary to make that application.
Okay, thank you.
Any more questions, Mr. McLemore? Thank you. Next, we have Cherokee Nation Health Services, Melissa Gower.
Good morning.
Morning.
I submitted my report to you, so hopefully you've all had a chance to look at that. If there's any questions on it, I'll be glad to try to answer those.
Any questions from Ms. Gower? Councilor Hawk.
On your ambulatory patient visits by clinic for June, this is here 06 to 08 on your chart.
Okay, what was your question?
Okay, on that chart,
Uh-huh.
it shows Wilmington for this, I guess for 08, 5569. That's how many actual visits, not appointments,
That's right.
for that year?
Right.
Okay. Then, I'm looking at third-party collections, analysis by clinic on your other chart.
Okay.
And I took the third party, divided it out by the visits, and I'm looking at some ratios here, some amounts that was, I guess, a money amount per visit collected third party. Can you explain to me the disparity between the clinics? Because I've got all the way from $196 up to $569.
Can you tell me your form? I mean, what are you doing?
I'm taking a third-party collection,
Okay.
Stillwell, on one of them,
And you're dividing that by
over
the
3
number
million,
of
and I'm
visits?
dividing it by the number of visits for that year, which is 5569.
Okay.
And I'm getting all the way from $196 up to Redbird's the highest, $569, third-party collections. Can you explain to me the disparity?
I can tell you some points off the top of my head. I can go back and analyze it and look at it and maybe give you specifics if you'd like.
Yes, please.
Probably, well, for one thing, is not every visit is billed at the same. So it depends on what type of visits those are, of how much is reimbursed for that visit. It depends on if the percentage of patients that actually have third-party billing versus the percentage of patients that don't have third-party billing. So an increase, if you had an increase in patient visits and not the increase in third-party, then possibly your percentage of non-insured are higher. That could be one reason. Those are just some reasons off the top of my head.
Okay, like the God Duty Clinic, I would have assumed it would have been number one.
Well, that's just because of because that's all private insurance, which is a lower rate of collections than our Medicaid rate and our Medicare rates.
Okay. Could you
I would assume.
Could you hazard a guess why is Redbird and Wilmington number 1 and 2?
No, no.
Because to be honest, I would have assumed our areas would have been lower, to be honest.
Yeah, I don't know. I'd be glad to go back.
Dr. Graham,
I think a
could
lot of it
you come up to we got people online, so they want to
I'd
be
like
able
to be offline.
to...
I think a lot of it is if you look at the patient mix, and we do this, and we just don't have it in front of us, we actually look at the patient mix and look at the source of the payment, and there's actually a really, because of Adair County and the poverty levels, there's a higher Medicaid population, and so with Medicaid, we get
It's more than, yeah, it's $270, I think, now.
dollars per visit, And so that really bumps it up. And if you look at some of the other areas that have a higher private insurance rate, the collections are actually lower because you may get paid $50 for just a routine visit versus if they've got Medicaid, they're getting the $270. So it's because we have such a high Medicaid population.
So as of
It's about the mix.
Bartlesville and Benita, where I would assume would have been higher per visit, because I naturally assumed insurance.
Right.
They're actually at the low end of the scale.
And they are, but they probably...
They're more private insurance
But they
than
have
they
more...
are Medicaid.
Right, but they do have a higher population of insured patients, but they're private insurance patients instead of
Which is paid at a lower rate.
Medicaid patients.
Okay, that makes sense. Go on, go to someone else, I'll look for my other questions.
Councilor Buzzard.
Yes, Melissa, I'd ask Mr. McLemore about the doctors diagnosing the patients as disabled there at Hastings Hospital. And I understand we don't do that at our Cherokee Nation clinics. Could you tell us
No,
why
I
we don't do
think
that?
we do the same thing as Hastings does, which is the diagnosis and the medical records piece. What none of us do, including Hastings, is actually filling out the disability forms
So
and the
who does that?
ratings.
Who would do that for that patient that's been there for 25 years? How
Well,
would they get that done?
doing that doesn't really, I mean, we provide the medical information for that. And then usually they go to a disability, a disability doctor that does those kinds of things. And Melanie just informed me, and I didn't actually even know this, that Social Services Department at the tribe actually helps people fill those forms out.
Okay.
But we do provide the medical information. It just takes so much time and involved in actually filling those out. It's a denial, and it would just take away from what our purpose is.
So there is a mechanism that they could go through to the tribe to get that assistance?
Yeah, that's what she just informed me. I didn't know that. But do you have something to add on?
Yeah, the only other thing is that you have to really do a good disability evaluation, you really need, need to have extra training, and our staff haven't had the training to fill out the disability forms appropriately. So in the patient's best interest, we try to send them the other route.
To get them approved.
Through social services, through a disability doctor that's been approved by the Social Security Administration. But we provide all the backup. We've written letters saying this is their condition, and we don't have any problem doing that. And because we've tried to support them and help them get their disability.
Right.
We just don't have the ability to determine and label them 100% disabled or 50% disabled.
The rating.
There's some really big formulas on how
So
to
the
do
Social
that.
Services Department actually helps them to make appointments to do that?
Yeah.
Okay, and if they're referred to a private doctor for that, then would contract health care pay for those visits, or?
They're usually referred by the Social Security Administration. They have a list of providers that they've approved to do disability evaluations.
Okay, all right. Thank you, that's good information.
Councilor Jordan.
Melissa, can you enlighten us as to how is our third-party collections at the clinics?
Well, I can tell you that if you look at our third-party collections over the last 5 years, that they have continually gone up.
Do you know what the total is for our clinics now?
We usually run, is it about 16 million? About 16 million a year. We set a goal each year to increase that by 5%, and we've been able to accomplish that goal. Now, at some point, you reach a saturation level where you start leveling off because you've become efficient at doing that. And so, and then this year there's some Medicare issues that are causing people problems with billing and, changes in regulations and all of those. So I think last year we were right at 16 million, and this year we're projected to come in a little bit above that.
Well, how does that play into our formula for our total cost to operate our clinics?
Okay. We get, I have a great slideshow about this.
Just an estimate.
I think we get about, what's our compact, 58? I think we get 58 million for our compact. Now, that's not just clinics, that's our whole health. So that's, that's everything. That's our community programs, and some of them don't even bill. So we get about 58 million in our compact, and then about 16 million third party.
Do you have a projection of what the clinic at Hastings Hospital, if it was split off from the hospital, would you have any projection of what that third-party collection rate might be? Or
I do not know.
Ed may be able to
If
enlighten
they
us
actually
to
break that out by medical outpatient, or, I
Do
don't
you
know.
break it down, Ed, can you break it down for what the hospital services
Like your
are
30 million?
in third-party collections versus what the clinic third-party collections are?
We could, and just a very rough estimate, I would think that it'd be about 18 outpatient, 15 inpatient.
Okay, so about 18 million outpatient.
Yeah, roughly. Now, that's just off the cuff. I would really like to go back and do some analysis.
Would you do that for
Yes.
us and provide that information to us?
Yes.
Okay. And Melissa, could you provide the third-party billing collection money by clinic for us?
Sure.
Okay.
You mean for a fiscal year,
Or
or?
for the previous fiscal year, let's say.
Okay.
I'm trying to get a handle on the actual dollars that we have to work with and where they come
Okay,
from.
this one does it by clinic, is that what you're wanting?
What page are you on?
It'd be the attachments to my report.
Did it break it down dollar-wise?
Yeah. Yes.
That's the
Mine's
one-
doesn't read very
that's the
good. I
one
don't know if yours
couldn't-
reads
I
very
couldn't
good or
find
not.
either. I don't know if
Okay.
we were running out of ink
I can
at that
send you
point.
original of
Okay.
this, is that what?
That would help, because that
Okay.
was the one I couldn't read.
Okay, sure.
I mean, I guess by the time it got to my book, it's so faded that
Mine's kind of
we're
faded
getting good
too.
credit.
Okay.
Okay, my next question is, do we mail out our medicine from the clinics now, like we're doing at Hastings?
Right, currently, we only do it at Nowata. We have a pilot site going on at Nowata. But we do have a plan to implement that.
So would that plan include possibly a timeline for the next year where we're going to do that at all clinics?
there's a timeline? That's Gloria's department.
Yeah, we hope to, by the first of the year, get that going. And we're in a little bit different situation than Hastings, because it's actually going to make money for us. Because right now, we're doing 90-day supplies in the clinics, and for a lot of places, you can only bill for 30 days. So when we go to doing a 1-month mail order that's just automatically renewed, we'll be able to start collecting more, because we'll be able to just collect every month for that patient.
Because on 90 days, you sometimes only collect,
No, you don't collect any. They won't even pay you for it.
so we're giving them 60 days free, basically. Or we're not.
In most cases, we're giving them 90 days free.
Right.
Okay, so you're not even getting the money for the first 30 days?
No, if you do 90 and they only pay for 30, they won't pay for the 30.
Medicaid considers that fraud, even though you're saving them money.
Well, we'd save price of 2 mail-outs.
Right.
Well, we tried, the reason, and I need to add this in there, is,
Right.
we tried to do 30-day at Salisal. We did a pilot there, but it was the volume was so much that we just couldn't do it with the current staff. It was just too much volume, because you have 3 times that many scripts to fill. And so at that time, we always try to do what's best for the patient, so we just decided we'll just forego that. It's better if we do 90-day for the patients and the current staff. But the way that we're going to be able to implement that is through mail order.
And we're getting robotics. So they'll be able to, at night, they can actually set the robotics system to fill the
Now, that's where it's automatic,
It's
right?
automatic.
It's like a robot kind of.
And they count it out, they put it in the
Yeah, so
bottle.
you can put it in the computer, all that it's going to fill that night. When you come in the next morning,
It's
they'll
all
be
done.
filled, yeah.
And you have to
And that's
stack it.
accurate, I mean, we're not
Very
getting too
accurate.
many or the wrong kind.
Actually, it's
or-
more accurate than human.
Okay. Okay. Well, real quick, because I know there's some other people that have got some questions, but have we thought about maybe opening up our clinics to after-hour visits. I know that's at a high cost, but is there a possibility of urgent care after hours?
Well, we have already some extended hours at some of the facilities. Extended being, I think it's an hour.
Yeah,
It's like
6
till
o'clock.
6, I think. And actually opening earlier in the morning. So at some of our facilities, we have a 7 to 6 shift. So it opens an hour earlier and an hour later. And, we would love to do a lot of creative things like that, and we've looked at those kinds of things. It's just money and staff to do that with. And so we continually analyze those options to try to do something.
So if we can get you more money, that might be a possibility that we could do some extended hours, more extended hours possibly.
Well, I think anytime you have more money, it opens up lots of doors.
And what we've looked at doing, because we've looked at this a lot, and we did extended hours 10 years ago, like till 7 o'clock, and
At Nowata, we did that.
we did it at Salina when I was there, and it worked. It worked well at some places, and some places it didn't. And we've talked about doing it even at Muskogee because it's such a big facility, and looking at, as we're looking at a lot of backlogs at Hastings, on PAPs and mammograms, maybe there's some way to do extended hours, not just for urgent care, but for more of the
And those would be
preventative
done by
screening things.
appointment.
Yeah.
Yeah.
And that's the last question I have is, if we do the extended hours, possibly move into the urgent care area, we would have to do something about increasing our walk-in load. Right now, I think, aren't we mostly appointments?
No. We have, at all of our facilities, we have appointments, we have same-day appointments, which are really walk-ins, and then we have walk-ins. So we have people that, can get up in the morning and if they have a phone and can get through, some of our phone systems are a little challenging sometimes, to actually call in as a walk-in, instead of actually walking into the facility, they can get a same-day appointment. Now, those fill up pretty fast. And then we actually have walk-ins from like 8 to 10:30 and then 1 to 3:30, I think, where people can actually walk in. And they're all triaged, and if someone doesn't show up for their appointment or, whatever, then we can put them in those slots.
So we actually are being flexible with our people out there. I mean, I get
Yes.
calls where people are saying, well, I got turned away because I was a late walk-in, or
Right.
and I'm sick and I need help, and what can I do? And I did not understand we were even given any room for walk-ins.
No, we have walk-in hours.
The places where we don't, though, like Bartlesville and Bonita, we have one mid-level.
Mr. Chairman, I really apologize for interrupting.
Oh, go ahead, sorry.
But it's
I didn't
11
mean to take so
o'clock, and they
long.
have that Supreme Court groundbreaking celebration at 11:15. I would move to recess this meeting until 2 o'clock. I think there's one.
That would be the next time. We have a motion on the floor and a second to adjourn,
No,
to
recess.
recess this meeting until 2 p.m. All those in favor signify by saying aye.
Aye.
Any opposed?
No.
No.
Acclamation?
Three no's.
I mean, I counted.
Roll call.
Yeah, I meant roll call, sorry. I counted 4.
Julia Coates. Brenda Cobb.
Yes.
Joe Crittenden.
Yes.
Jody Fishinghawk.
Yes.
Meredith Braley. Nell Fulbright. John Garvin. Chuck Hoskin Jr. China Gore Jordan.
Yes.
Chris Soap.
No.
David Thornton. Kara Cowan Watts. Bill Anglin. Jack Baker.
Yes.
Harley Buzzer.
Yes.
We have 10 yes and 4 no.
We are recessed until 2 p.m.
I don't know what that is.
That's the only one I'm concerned with.
Pretty much.